2 minutes ago, before getting started with Dr. Torresan, I was reminded that when I was a young student, I was sent by my mentor to talk about sinusitis in a GI tract conference, and I was considered, my speech was considered quite out of topic or off the topic, and I as a weird speaker. However, now the situation has entirely changed, and I'm happy to see that Dr. Torresan's speech was quite in line with this conference. So the symptoms may be various and varying, and from the upper ways symptoms to other symptoms. In the last few years, our approach to this disease has changed, especially ENTs have started talking about low airways, and so to cooperate with pneumologists as well as gastroenterologists more recently. So we have a more holistic approach to such diseases. So we may have the following symptoms: laryngitis, reflux laryngitis, cervical dysphagia, and globus pharyngeus that in the past was attributed to hysteria in women. Actually, stress might be caused by reflux. So it was a hysterical kind of syndrome, but phlegosis due to reflux, and then chronic cough up to more severe complications up to the laryngeal and tracheal stricture stenosis, and as well as laryngeal carcinoma. And of course, laryngeal syndromes took slightly longer to get into our approach, and but also rhinosinusitis, endotitis media, and dental erosion as far as we are concerned. So the Montreal classification, dating back to 12 years ago, of course, but it's the foundation for most of the research work that has been ever since conducted. So then, at the time, certain associations were postulated. For instance, the association of reflux syndrome, laryngitis, and asthma from reflux were at that point, back in 2006, accredited as manifestations of laryngopharyngeal reflux. But then more research work started late in the 90s, early in the new century, and manifestations were studied that until that time had been considered as infections or inflammation not having to do with the reflux, such as sinusitis or idiopathic pulmonary fibrosis, and also the recurring media otitis that at the time was the most difficult to demonstrate. From this research work, a scoring system was developed to diagnose reflux by especially to be used by ENTs, and so and then to try and plan for a treatment in case of severe lesions, referring the patient to a gastroenterologist. But this scoring system allows us to provide a certain diagnosis of laryngopharyngeal reflux, so a supraglottic edema or even subglottic edema, should the patient tend to, especially at night time, inhale the reflex, and erythema or hyperemia of the mucosa, vocal folds edema, posterior or diffuse larynx edema, posterior commissure edema. This is the portion shared by the respiratory airways. and then granuloma and endolaryngeal edema. Such a scoring system allows us to score values from 0 to 4 and to provide a certain diagnosis of laryngopharyngeal reflux. Okay, the upper airways, first of all. A few years ago, we started talking about them, and these are the very first papers that were published on the topic, especially in children, where the reflex is more frequent due to anatomy. And Professor Torres-san will explain what we mean by this. And the pH concentration have been studied, and their correlation with upper airways problems. And so we started to see that acidic reflux might also actually affect the upper airways with chronic infection of these airways. In the following years, a first review of the literature has been conducted, and there was a certain evidence, although not a very high evidence, of this correlation. Although controversial, was still the association, but especially because at the time only anti-secretion substances were used that were not very effective, and so this isn't sometimes the best approach to treat these diseases. Many cohort studies, population cohort studies were conducted ever since, and these are studies conducted on almost 20,000 patients in the general population, and there is a statistically significant correlation between the levels of acidity at the laryngeal, pharyngeal level and chronic rhinosinusitis, especially without polyps. But this is because when there are polyps, other substrates or different substrates might be present compared to chronic infections. There should be a genetic factor contributing to it, in other words. So, especially with nocturnal GERD, this study was conducted on 5,000 patients, or over, actually. 5,000 patients, and there was a recurrent infection of the upper airways, and there were high acidity levels in the laryngopharyngeal tract. So this is a 10-year study that posed the GERD as a risk factor for rhinitis, rhinosinusitis, non-infectious ones, and especially to the ones non-responsive to current treatments. This is an update on the guidelines published to that date, and it is stated that the American Academy of Latino, that is our American Society, does not support the use of IPIs to treat children's rhinosinusitis in the gastroesophageal tract, because it's better to use alginates. But as far as adults are concerned, for the time being, there isn't any official statement, but it is certainly required. So this statement by the American Academy, the Society of Rhinology and Allergy, we may see that chronic sinusitis and pharyngeal and laryngeal reflux have a grade B of correlation, and it is absolutely necessary to have a therapeutic guidelines to approach these problems, and especially for chronic pathologies non-responding to common treatments. So we have come to this to the last few years with a demonstrated association between the diseases of the upper airways and GERD. Let me now skip the other papers that have associated it with allergic rhinitis. And the role of adenoids has been proven in these children, because by increasing the negative thoracic pressure during the night, reflux is favored, but also at the rhinopharynx, by monitoring pH values in the 24 hours. There is a vicious circle that may aggravate the reflux, and all this is reflected in inflammation of the mid-ear. And so that there is a chronic inflammation due to the inflammation of the tonsilliary tissue, as and the maintenance of such an inflammation that is due to GERD, which causes forms of chronic otitis non-responsive to treatment, that we may consider as being associated or related to GERD. And then in the afternoon, we'll talk about our personal experiences. And finally, to now turn the floor to the ophthalmologist. Let me say that the nose is very well connected, as well as the mid ear and the eye, to the lacrimal duct. So this is just to show that we may very well think of an inflammation reaching to